afternoon. My name is Cynthia Kamga and I am a student pharmacist. I will be presenting a case today on a patient with febrile neutropenia. The patient, chief compliant, says, I feel bad. It's a 2-year-old white female. Her mom said she felt warm this morning and she presented lethargic all day. So the primary medical history of the patient says she has acute lymphoblastic leukemia, and her family history, she has no family history, which is pertinent. Her social history, she lives at home with her mother, her father, her siblings, and nobody smokes in her house, so she has not been exposed to any form of smoke. Her family owns a dog and they also have 6 chickens as well. Medications and allergies. She has no pertinent allergy or no known allergy for now. She's currently taking sulfamethoxazole and triamtoprene 200 milligram over 5 milliliters um, twice daily on Saturdays and Sundays. She's also taking clotazidine 0.12% oral solution, which she take 15 milliliters by mouth 3 times daily. Ondansetron 4 milligram over 5 milliliters oral solution, 2 milliliters by mouth every 8 hours as needed. Dexamethasone 2 milligram by mouth, and that's twice daily as well. And she's also taking famotidine 10 milligrams by mouth twice daily, vitamin D and calcium supplements 1 tablet by mouth daily. Her immunizations, she's up to date with her childhood immunizations. And her review of system, she has fever and have redness around a pot site. Her vitals today, her blood pressure was 100 over 58 milliliters of mercury and her heart rate was 118. Her her maximum temperature was 39.4 and her respiration per minute was 25 respirations. Her height is 73.7 inches. Her weight is 10.5 kilograms and her BMI was calculated to be 19.2 meters square. Her lab result shows that she has a white blood cell count of 3,000. She has segmented neutrophils of 2% and her bound form is 1%. Her creatinine clearance was calculated to be 31.6 and her ANC level was calculated to be 90%. The problem stated, the patient has febrile neutropenia. Evidence of problem and rationale for the plan. The patient has leukemia, which puts her at high risk because it weakens her immune system by reducing her amount of white blood cells already. And her temperature today, which was her maximum temperature, was 39.4, which is already higher than the normal temperature, which is 38 degrees Celsius. And her ANC was calculated to be 90, which is way below normal ANC level, which is supposed to be 500 neutrophils per microliter. She has a redness spot on her skin, which indicates the disruption of her skin, and barrier tissues, thus exposing her to infections. Her mass score was 20, which put her at high risk and as such should be treated as an inpatient. And based on the NCCN guideline recommendations for patients with febrile neutropenia at high risk, they should be on antibiotics, precisely the anti-pseudomonal beta-lactam with or without the MRSA coverage. However, my recommendation today will be monotherapy of the anti-pseudomonal beta-lactam. What are the goals of the problem? The goals of the problem here, first we want to prevent morbidity and mortality until blood culture results are obtained or available. So we want to reduce the patient's temperature and initiate vancomycin within the next 1 hour of of admission, which is recommended by the guideline due to the skin issue, and increase her ANC level and restore her skin issue. So the drug regimen, my recommendation first will be to administer the vancomycin IV, 20 milligram per kilogram, and based on the patient's weight, in this case is going to be 210 milligram every 6 hours, and that's IV vancomycin. And secondly, initiate cefepime, 550 milligram per kilogram, and based on the patient weight, in this case is going to be 625 milligram every 8 hours for 72 hours. That's 3 days. And also Tylenol to reduce the temperature, and that's gonna be 10 to 15 milligram per kilogram, and in this case for this patient is going to be 105 milligram every 4 hours as needed for the temperature. So safety and toxicity monitoring. It is important to monitor the patient's renal function to avoid nephrotoxicity, and also monitor neurotoxicity in case of cefepime and vancomycin. And precisely vancomycin, we need to monitor for vancomycin infusion reaction, and thus making sure we are respecting the rate of infusion for vancomycin to avoid any vancomycin infusion reaction. And also efficacy improvement and monitoring. We should monitor the temperature to make sure it drops, monitoring the white blood cell counts, making sure we are getting to the optimal level, which is 500 neutrophils, and also to stop cefepime when the cultures are available, and initiate a new regimen based on the results that we get from the culture. And those are my recommendations, and that'll be all. Thank you. Do you have any question for me?